Good evening, everyone. Thank you for joining us at the Ontario Pharmacists Association, Part 2, to discuss disruptions in the pharmacy profession. I'm Mike Kavanagh, Chair of the Board of Directors at OPA, and I'm joined in our webinar studio tonight with OPA's Executive Vice President and Chief Pharmacy Officer, Alan Malik. Before we begin, if you're having any technology issues, please call the number that's at the bottom of the slides, or you can also email us at education@opatoday.com. However, any technical issues are best handled by calling the phone number. On our last webinar on April 18th, we discussed the changes that we are facing in our profession and what OPA is doing to address them, and then we're addressing some of your questions. Based on the large number of questions we had at the last webinar, we wanted to conduct a second one so we could spend some more time hearing your thoughts and concerns. So if you were on the webinar last time, we will be reiterating some of the first messaging. And if you do have a question, just ask it in the Q&A box at the bottom. On tonight's webinar, Alan and I will spend the first few minutes recapping some of the changes or disruptions that we've been witnessing in the pharmacy profession and have been challenging to our practice. Some have been very quickly, and others have been percolating for some time. Individually, each disruption impacts pharmacy professionals and how they deliver care to their patients and how owners and managers conduct their business. Collectively, disruptions are quite significant and in some cases can make or break our pharmacy operations. So Alan, why don't you start by providing us with some of the context?
Thanks, Mike. Next couple of slides will help to illustrate the various transformations that have taken place over the last decade or so. In 2006, the Ontario government announced an outright ban on pharmacy rebates with the passage of the infamous Bill 102. And while legislation did introduce the concept of professional allowances, these were tightly defined and they became highly restricted for very specific uses. In 2010, amendments to regulations under the Drug Interchangeability and Dispensing Fee Act, or DIDFA, and the ODBA lumped these professional allowances under the term of rebates, effectively banning them as well in the province of Ontario. And this amounted to the removal of about $750 million from the Ontario pharmacy ecosystem. In October of 2015, once again, the Ontario government used its majority to pass regulations and policies that would see mandated funding cuts amounting to $150 million per year for a 3-year period. And it's expected that this could continue.
All right. Now we fast forward to 2018. And we're only in May, and already this year is shaping up to be one of the biggest that we've ever seen for transformations in pharmacy. So January saw the introduction of the new challenge for pharmacy sustainability with OHIP Plus. So the program does have great access to medications for anyone under the age of 25 with either insufficient or no drug coverage. However, it still had unintended consequences, including significant financial impacts to pharmacy. January also saw the launch of a dramatic minimum wage increase. And while it was not as intended as a specific hit to pharmacy, it impacts all sectors, and yet it was another major cost to pharmacy impacting the business environment and changing and redistributing the wealth among society. Changes to the patented drugs are also on the horizons with the PMPRB that will also impact pharmacy's bottom lines. Also, likely to come this year are the changes to the Employment Standards Act, and specifically changes to pharmacist exemptions. What this means is pharmacists, as individuals, may have greater protections under the Ontario labor laws. As many of you know, OPA has been the leading voice of advocacy on this file and has submitted its recommendations early this year, calling for changes to the exemptions from the Act as a matter of fairness to all pharmacists. But perhaps the greatest impact to pharmacy has been on the changes that we're dealing with now, in one way or another, from the Pan-Canadian Pharmaceutical Alliance, which were implemented nationally on April 1st. These changes have decreased the pricing on about 70 commonly dispensed generic drugs and will certainly affect how pharmacies right across the country operate. We'll speak to these changes a little later in the presentation.
In the March 2018 throne speech and provincial budget, the Liberal government announced an enhancement of OHIP Plus that would see the eventual elimination of seniors' deductibles and copays beginning in August 2019. Now, OPA has been lobbying for this for many years, and we welcome this as a way to provide greater access to medications. As it relates to seniors, this would position all pharmacies on a more level playing field. Competition would simply shift away from prescription pricing and would focus more on service, quality, and our relationships with our patients. And this would be a benefit to the system, the profession, and to patients. But our advocacy on this file is still not done, as we would like to see this implemented this August, not 15 months from now. And we'd also like to guarantee that this will not be another instance of pharmacy picking up the price tag for it. New reporting by payers under the Health Sector Payment Transparency Act will also have significant impacts to all healthcare providers, including pharmacy businesses, individual pharmacists, and associations including OPA. Throughout the consultation period, which just ended, OPA has been extremely active and vocal on this file, given the complexity, the confusion, and the potential for unintended consequences. We are pleased to announce that the government acknowledged our concerns and recently extended the deliberations on the draft regulations until fall of 2018. We expect to work with whichever government takes power to further understand the impacts to pharmacy and the overall health system. Ensuring that we are transparent to the public is an important endeavor and one that we support. But quite frankly, this is landmark legislation, provincially and nationally, and it will require additional thought, processes, and time to consider its impacts and to ensure that the original intent of the legislation is reflected as it is intended, to support and respect transparency.
I'd like to stop here and reflect for a moment as a business owner on some of these changes. As some of you may know, I recently opened a store in the Kawartha Lakes area. And despite the frustrating changes to our profession, they're coming at a time when I feel that the services as a pharmacist have never been needed more. In fact, some of the clinical services that we're implementing include flu shots, travel vaccines, smoking cessation, meds checks, even as cumbersome as they now become, prescription synchronization, so a variety of services. In addition, I'm working closer than ever with our pharmacy technicians, who enable me to streamline our workflow so that I can provide these clinical services. We actually have 4 on staff. With more than 4,500 pharmacies in Ontario, we're often the first point of contact for many patients. Pharmacy professionals can do more to improve or optimize the health outcomes of patients. It just seems that we're being expected to do more with so much less, and OPA recognizes that and the strains it puts on your practice. We've already seen the tangible evidence of our value. Let's look at flu shots. In 2012, with 600 pharmacies participating, we administered 250,000 flu shots. This year, pharmacists in approximately 2,600 pharmacies have given more than 1.2 million flu shots. Local pharmacies are convenient healthcare centers. There's one pharmacy for every 10,000 Ontarians, which is amazing. It means that our convenience and our experience can help our patients even more, when and where they need us and close to home. It's one of the reasons that I opened another store. It's also why I'm adamant that the pharmacy professionals should be allowed to do more. Sure, we can offer travel vaccines, but why not all vaccines, especially something like shingles vaccines for seniors? Other provinces can assess and treat minor ailments, and there's nothing stopping us in Ontario except government regulations and fair and reasonable funding. And given the strains we're seeing in hospital emergency departments and delays in seeing a family doctor, patients support pharmacists taking on more in this area.
I'd like to go back to the recent changes announced in the generic pricing framework. In general, Ontario pharmacists support making medications more accessible, especially to our most vulnerable populations. But this is making a big dent in pharmacy. The Pan-Canadian Pharmaceutical Alliance calls for a reduction of 25 to 40% of the prices of 70 of the most commonly prescribed drugs in Canada. In some cases, that's up to 90% of their brand name equivalents. So how can anyone say this is not significant? It's been projected that the impacts are expected to reach an annual savings of up to $3 billion over the next 5 years right across the country. It's a noble cause, no doubt, if indeed these savings are being used to bring more medications to market for the benefit of Canadians. But what of the unintended consequences and the business casualties left behind, specifically pharmacies and the generic industry? This is indeed frustrating, especially on top of the long list of cuts we've endured dating back to 2006. What is crystal clear now is the fact that our funding model is completely unworkable in a patient-focused health system. For years, Ontario pharmacy has been seen solely as a cost to our government and not as a profession to invest in. You have not been acknowledged for the tremendous value you can bring in terms of efficiencies, nor have you been recognized for your skills, your expertise, and training to improve patient health outcomes. Pharmacy revenues are largely dependent on the dispensing of a product, and there's little opportunity or financial incentive to shift to a more patient-focused care model when cuts are the order of the day with zero reinvestment in the profession. And we are now seeing the impact of generic price reductions. There's no recognition of the losses you are now realizing with drop prices and the absence of a washout or opportunity to release existing inventory. And there's no recognition of the ramifications of price depreciation and lost revenues and markup. With the exception of Dalton McGuinty's minority government in 2011 to 2014, all of the cuts we've endured and continue to endure have been introduced by a majority government. There is little leverage to be had by an advocacy organization like OPA with majority governments, and that's why this June's provincial election will be very important. Now, don't get me wrong, I'm not saying majority governments are inherently bad. We could be looking at a very new era in Ontario politics that could be, in fact, be a majority government, and this is why OPA must remain and will remain extremely active during the election campaign and beyond to help influence each party's political platform and underlying philosophy to be more respectful of you, Ontario's most accessible and undervalued health professionals. In the meantime, we can only live with the here and now. It's a good time to review your current workflow, your inventory levels and staffing, and to ensure that you are maximizing potential revenue opportunities from all possible professional services while carefully managing inventory levels. Consider how your patients might benefit from meds checks, travel vaccines, flu shots, pharmaceutical opinions, and find creative but indeed defensible ways to leverage one service off another. Review the OPA suggested fee guide and look for opportunities for billable services that can also help your patients.
Alan, you're indeed right that we're at a crossroads right now, and we need to find different ways of doing things. So as an OPA sales pitch, Bruce Cochran will be from the TV shows Dragon Den, and the Disruptors will be at the conference in June, and this month we'll feature him in the Ontario Pharmacists magazines. He talks about the need for pharmacy to adopt new ways of doing things and not waiting for other decision makers to dictate our work. On first blush, you might object to this, thinking it's impossible to do because healthcare is highly regulated. And while that may be true, conceding to the status quo solves nothing. To survive, you may need to look at doing things differently and the need to innovate. Take Uber as an example and how it's revolutionized transportation and Apple in the music industry. Pharmacy must transform itself. This is a precarious time for our profession, but that may also bring out the very best in us. I'm excited about the potential for pharmacy to play its greatest role in healthcare yet. But I'm no different from the rest of you. I'm not naive, and I'm a realist. There's some pretty big obstacles that have been put in front of us as owners and as pharmacists. My suggestion, though, is to get involved in your profession, and I can't stress this enough. The one way to do that is to join OPA. We need your voice and your involvement in discussions with ministry on projects such as meds checks. Reshaping it is once again, we're looking to reshape it once again to ensure that this time we have the program right, and a program that is patient-friendly, provider-friendly, and that means doable in a busy pharmacy environment, less restrictive and more flexible, and capable of driving better health outcomes and system efficiencies. We also need your help in participating in new projects and initiatives like those led by practice researchers such as Open to demonstrate our value. OPA remains very active in driving pharmacist roles in primary care through our membership in the Ontario Primary Care Council and in mitigating the dangers of addiction and overdoses with our current opioid and pain management proposal and our representation on the Opioid Emergency Task Force. Just a few examples of the advocacy work we're doing for you. So we are doing a lot, but we need your help to deliver a message that we embrace transformation and that pharmacy professionals can provide tangible solutions to some of healthcare's biggest issues. Right now, OPA is 10,000 members strong. We support more than 64% of pharmacies in the province. The pharmacy sector employs more than 60,000 people in Ontario and has a total direct impact of $6.3 billion. This size and breadth can have a huge impact at Queen's Park, but we need to be louder and stronger. As OPA's chair of the board of directors, that's my goal for the organization of the profession, to grow our membership so strong that politicians and policymakers have no choice but to hear our message and consider how we can make the future of healthcare in Ontario.
Thanks, Mike. All right, that's enough from us. Let's open up the webinar now for your questions. As mentioned, we do have a lot of participants on this webinar, and we'll try to take as many questions as we can, and we'll even try and group them together where possible.
All right, so the first question that we've got, and it's very pertinent to where we are right now, is if we have a new government, will your efforts be lost? And the easy answer to that is no. We've been working closely with all three parties, probably for about 6 months or more, or we've ramped up our efforts with all three parties over the last 6 months. But what's also important is we also work very closely with the bureaucrats that stay in government, and some of them won't change depending on the different government that's in power. So we work very closely with the people that are the decision makers that inform and influence the politicians, and so that our current efforts will remain to make sure that all three parties, the three major parties, are aware of what we can do, but also to continue to work closely with the bureaucrats on operational issues for pharmacy.
Okay, I got a question that was sent in. How do I expand my scope of practice when I don't have enough time right now? Short question, powerful, no question. We hear this a lot, and we've heard it for quite a number of years. I guess the best way to answer this is to take stock of how it is you're functioning, and along with your staff, and ask yourself a question: are you utilizing your staff to their fullest extent? Do you have technicians, pharmacy technicians, that can take some of the weight off of what you're currently doing, so that you have more time for patient-focused care services such as med check, such as pharmaceutical opinions, even OTC consultations? These are the roles that only the pharmacist can play, and so we need to find ways to do things differently and more efficiently. So tech usage it's there for us. Technicians are available. They have a scope of practice that can help relieve some of the time pressures. Time is actually a finite. We only have 24 hours in a day. It's how we use that time, and we just need to make sure that we are all using our time efficiently.
All right, another question that we've got asked is, are staff pharmacists represented on the board of directors? And this is actually one that I personally get asked quite frequently. Our board of directors is very diverse at the moment. We have two pharmacists in particular who spend their time just solely as staff pharmacists. We have another one who spends part of her time as a staff pharmacist as well as working operationally for an independent chain. We have lots of people on the board who are from independent pharmacy as independent pharmacy owners. We do have some from corporate environments as well. And then of course we have our hospital pharmacist. We have two student pharmacists, and we also have two directors at large, and we also have a voting technician. So this is a fair question, because we do get asked a lot if OPA is representing you, whatever your practice may be. And based on the diversity of the board, I'd say we do our best to try to hear the voice of every pharmacist that we can. Not only that, the board is there to provide the governance of the association. A lot of the work that's done to understand the direction of the association is done by our wonderful staff here at OPA. And as many of you may have seen recently, we did a membership survey, or actually a professional survey that went out to members and non-members, pharmacists and technicians alike, and students, to try to get a large-scale opinion on where OPA is and what OPA should do. And I can tell you that staff and the board of directors very much appreciated your input on that. And I think that it will certainly help guide us in in giving some direction. So again, it's a very diverse representation on the board, but I would say it's fair to say that we represent the voice of as many pharmacists in Ontario as we can, as well as technicians.
So I have a question that came in. I'm going to tackle two questions at once. One of them is actually a relatively simple one. It's a quick answer to the question, where can I find the OPA suggested fee guide? The quick answer to that is that it is on the OPA website. It is available if you are a member. I would strongly recommend that if you're not a member, that you take advantage of all the many benefits that come with OPA membership, including accessing the OPA suggested fee guide. There's a reason why this fee guide is gated. It is a fee guide that is, as I said, suggested, but it's something that we want to be very careful in terms of having access to individuals outside of the pharmacy system. But you can definitely find it on the OPA website. As a member, log into the website, look on the resource tab, and on the left-hand side towards the bottom, you'll see a tab for the fee guide. Next question was, what do you suggest we do to lobby government to understand the challenges we are facing? This is a great question, and it's something that we have taken efforts to address with membership, and we've addressed this through a number of our e-bulletins. We have provided and provided access to an advocacy kit. This is particularly useful now, especially as we go into an election campaign, and candidates are from both the current government and from all political parties are open to meetings when they're not on their traveling roadshow. They are open to hearing from their constituents. And so the OPA Advocacy Kit, which can be found on the OPA website, and I believe it's on the pharmacistcare.ca website, you can access speaking materials that you can help deliver the message that OPA is trying to deliver through its advocacy efforts.
Okay, the next question that I've got. Very few patients are willing to pay for some of our expanded scope, particularly something like renewals. Are there any suggestions? So again, I'll speak from my experience as a business owner and a pharmacist, and not necessarily just from a general OPA position, but the one thing that we found very, very effective in our store is to actually advertise the pricing, be very upfront. And we've posted pricing, so when patients come in, they're very aware of what our fees are for certain services. That's at least setting the expectation when they come in. We also make sure that they understand why we're charging a fee, explaining the training that might go into this, the decision-making process, particularly around renewals. That helps them understand that this isn't just simply a, let me sign on the bottom line and give you a prescription and go out the door. There's actually an assessment that must come with it to ensure that this medication is something that still needs to be continued. And we found that certainly you're going to get pushback from some patients. I don't think it's unanimous that they're in agreement to pay for the service, but that's fine. If they want to take the time to go to their physician to get the service instead, then we certainly respect that. But I think the biggest thing for us, where we were actually able to have success, was once we started to advertise it and make sure that we communicate it. And we've ensured that all our pharmacists are on the same page in terms of messaging, that we're not confusing patients with what we say, but ensuring that they're hearing the same message from us. So I think that's the best way. It is a change. These are things that we have typically not had to do in the past. But it's not a bad thing. If these are the services that we are offering, we should certainly be comfortable asking to be remunerated for them.
So a question that, a question that has come in is, where do we sit right now on the matter of the $35 million reconciliation process? And as you may recall, this stemmed from the funding cuts that were implemented in October of 2015 that led to a number of different policies. And at the end of the day, it was determined that those policies did not deliver the estimated savings the government had hoped for, and therefore a reconciliation process, a payment off of the top of your monthly reconciliations was put in place to the tune of it was 2.8% that was deducted from your monthly reconciliations. The plan for that, just to help members recall, the target to hit was $35 million, and there was a time limit put on that to the end of February, meaning, in other words, that whichever came first, the $35 million in savings or February 28th of 2019, once one of those was hit, the early of the two, the reconciliation would stop. This is a moving target, and I guess the only thing I'm permitted to say due to non-disclosure agreements that pharmacy and OPA was forced to sign with the ministry, all I can say is that we are on track not only to achieve the 35 million, but we may even do so before the timeline of February 28th. This is probably in part due to the addition of claims as a result of OHIP Plus. There's a greater number of claims that they are looking at, and this has led to an escalation in the time frame, or a speeding up of the time frame. So we may be in a very good position and may achieve that $35 million sooner than later.
Okay, so one of the questions that was asked was, what is OPA doing to build better relationships between pharmacy technicians and pharmacists? And this is an interesting question. I think the best things that we can do is more than anything, attend something like conference or speak to your peers. And we're happy to facilitate that. And there's been conversations at conferences in the past for sure about how technicians can be used in your workflow. But it really, in all honesty, the best thing to do is talk to peers who are really utilizing pharmacy technicians to their best. Because I can tell you from my own standpoint, having a technician in our pharmacy has made life a lot easier. It's freed up a lot of extra time for our pharmacists to provide professional services. I still feel we're underutilizing technicians in our own pharmacy, and we're looking at opportunities at where we can expand them more, particularly through novel programs like synchronization. That I think that's an area where a technician can really guide the program and really assist the pharmacist. And they can also batch fill a lot of the prescriptions at once and take that load off, where the pharmacist is just limited then to the technical check or the therapeutic check, sorry. But the best way to do it, come to an event like conference where you can interact with a lot of your peers and find out some novel practice settings where pharmacists are really utilizing their technicians to the best of their practice.
Okay, I'm going to try to answer a question. I may look to Mike to help supplement some of this. Question being, can OPA fight for our wages for pharmacists, as wages seem to be going in a downward direction? I guess the first point I want to say is that OPA is, unfortunately, we are not a trade association. We're not a labor association, and quite frankly, I guess the quick answer is that this is not a government advocacy initiative, given that government does not pay pharmacists. Pharmacies pay pharmacists. So there's very little that government can do to have any type of impact on the wages that are being paid. However, what I will say is that the work that OPA is doing on the profession's behalf to advocate for increased scopes of practice, to look at a dispensing fee that is fair and appropriate, and that recognizes the value, not the cost of dispensing, but the value of dispensing. Because you only know too well, there is not only a technical component to dispensing, there is a professional and a cognitive component. So the dispensing fee needs to truly reflect the value of the service that you are providing. If all those are in place, fair dispensing fees, scopes of practice that are funded in a manner that perhaps would be similar to funding of other health professionals for similar types of services, then pharmacies themselves become more sustainable, and there is perhaps a greater opportunity for pharmacies as businesses to transfer some of those value propositions to their employee pharmacists. Mike, I'm going to maybe ask if, in case I've missed something.
Yeah, no, Alan, I think you touched on it appropriately. It is a challenge that OPA has faced. I've been on the board since 2010, and this is a question that keeps cropping up. The role and the mandate of OPA is an advocacy organization for the profession. We are not a trade association. We've never been designed that way. And really our interactions are limited to stakeholder engagements and government advocacy. And to Alan's point, really the role where we do support pharmacists in terms of wages is, one, through education, making them more valuable to their employer, which has certainly been effective. In some cases, we try to ensure that there's enough money in the system to fund pharmacies and pharmacy operations, which also includes pharmacists. But we don't have that direct link, so to speak, between talking to a pharmacist and a pharmacy employer. That is not our role. We even went down the road about 4 or 5 years ago of investigating billing numbers, independent billing numbers, at the advice of our members. And this shows the value of a membership and raising your concerns at an annual general meeting or at a conference, because we did have this raised by members that we should be investigating this, and we did. And actually what we found, much to my surprise personally, was that most pharmacists were, about 2/3 were actually not in favor of an independent billing number system when we went out to membership and asked that question. Now, that was 4 or 5 years ago. Things may have changed. We can certainly reinvestigate that. But the last that we've heard is pharmacists were actually against that. And so we've continued to do things in certain ways based on what we hear from our membership, but our key role is certainly advocating with government and keeping as much, and third-party payers, I shouldn't limit it to just government, and keeping as much money in the system that we can. Another question, just to switch gears, is can OPA recommend a fair dispensing fee that is a minimum fee for all pharmacies to charge? I don't think we have, in our fee guide, I don't think we actually have a dispensing fee recommendation. We can't, it's a very delicate situation. Obviously, we can't tell pharmacies what they should be charging as a dispensing fee. There's laws that prevent that as anti-competitive, but certainly something that we could be doing is looking at what the cost of dispensing is, and we've done those studies. It's been some years now, and how do we maybe look at what the cost of dispensing is, what's fair remuneration, especially with the changing demographic of pharmacy right now, and having the implementation of pharmacy technicians and pharmacist roles moving more away from just technical and more therapeutic. So it's something that that comment, I appreciate that comment. I think we'll take it back and maybe consider it for something as part of our fee guide. So there was a follow-up question too. Do we change OPA's role to a trade union for pharmacists? And this is a big question, and it's a very difficult one to answer, because I'm just one member. Even though I'm on the board, I chair the board, at the end of the day, I'm still just one member of the association, and it's not something that I would be able to say one way or the other. But this is something that we're a member-led organization. And if this is something that is very critical to members, then we need to hear it. We need to hear it loudly, and so that the board and our membership can debate and decide these directions. So,
thanks, Mike. on that same note, I'd just like to add one other component, and we do get this question quite a bit, the question of can OPA become a union? I think the point that also needs to be understood by members is that even if OPA were to decide that that is the best approach, and I'm not suggesting at this point in time that is the right approach, but the decision to become a union is not solely, it's not within our ability, it's not within our power to declare ourselves a union. To become a union, you do need government permission. And the analogy that everyone seems to look at, we look at it as well, is the relationship that Ontario's doctors have and that the OMA has with the Ontario government, and that the Ontario doctors through the OMA are a de facto union. It's not technically a union, but the nature of their relationship is structured in a very similar fashion. That took an act of government, that took legislation and regulation to define that. And the question, if we look at what is going on within the world of medicine, the challenges that the OMA have right now with the Ontario government, it does not seem as if government is amenable to bringing another health profession into that same type of a scenario. I just want members to understand that this is not just a matter of OPA deciding to become a union. It does need and require government approval.
So one of the kind of shifting gears again is, does the government realize the impact of OHIP Plus to pharmacy? This is where we run into the sensitive issues of advocacy work. When OHIP Plus was announced, it's fair to say the government was not aware of the impact that it would have on pharmacy. They knew the dispensing fee was less, but they didn't see some of the other impacts that may have come along with that. So we did spend considerable time and effort articulating how pharmacy would be impacted, pharmacy business, and therefore pharmacists would be impacted by OHIP Plus. And I know a lot of people would have, and if I was on the other end, I would have liked to see an OPA, picketing and being loud and vocal on this issue. It's very hard for OPA to argue against free drugs for children. And that's, at the end of the day, from a government standpoint, this is what that program was. Their argument is very clear. We were trying to make medications more accessible for anyone under the age of 25. While we did have an impact, politically, it's one that's very difficult to win in the public space. So we did make this very clear to the government that the impacts that we were facing from OHIP Plus, and on multiple occasions we've raised these concerns, and not just us. Some other advocacy organizations raised the concerns as well. And I think that the government, hearing these concerns and hearing these impacts, did in some ways end up beneficial, and the fact that we were supportive of the program did end up beneficial when you see a program like OHIP Plus being expanded to seniors, which does have benefits to pharmacy, significant benefits to pharmacy, and the benefits probably and actually will outweigh the impacts of OHIP Plus to children. So while I understand people's concern that we had an impact and we should be loud, we kind of have to pick and choose our battles. And in this case, I think being diplomatic about it, democratic about it, probably paid off in the long run with the expansion to seniors.
Question has come in, and it's a very common question. Why do all government problems exist in Ontario, and why does Alberta have so much success? This is a very timely question, especially given discussions that are going on right now in the realm of pharmacare, national pharmacare. But let me back up a step. Why do all government problems exist in Ontario? I would suggest that size does matter in this particular scenario, that the level of investment that governments need to make in enabling more pharmacy services expanded scopes of practice that are funded, that they have the size, because of Ontario's size. These are large level investments, and there comes risks with that. So their government is not averse, certainly, to expanding scopes of practice, but they also want to be able to determine the value proposition. But to getting to the nut of the question, why do the problems exist in Ontario? Why are we seeing the large cuts, in some cases very draconian, going back 10, 12 years? Some of them were massive cuts, and why are we only seeing them in Ontario? Quite frankly, we do hear, and we talk quite a lot with our provincial counterparts, and life is not always as rosy as it seems in other jurisdictions. In fact, and the reference to Alberta, the success they have had, that is also a shifting market, and the whole concept of value-based reimbursement, value-based investments by government, that's starting to become a topic of discussion in the province of Alberta, and the association there is also now navigating many of the challenges that we have been facing over the past several years. So it's not that it's rosy in every other jurisdiction. We tend to see the ramifications of what goes on in Ontario. That's the market we live in. We are the biggest market, and so the cuts seem to be very, very visible. But we are not alone. And the reason I raise pharmacare is that part of our messaging is going to be not only about things like a national formulary, but its inclusion of what would ideally be a harmonized set of services: common ailments, minor ailments, assessment and prescribing, vaccines, full access to vaccines and other injectables, the ability to independently prescribe for other types of conditions and to adjust therapies up and down, not just for Ontario drug benefit, but for all Ontarians. This is what we are looking for with a national pharmacare program. It seems as if we are taking baby steps, but progress is being made. It's unfortunately, advocacy is just a very slow-moving boat.
So a couple of questions. I'm just going to follow up on one back related to the OHIP Plus program, because I did see some comments on it. That why did OHIP Plus decide to pay for children who already had coverage, and why didn't OPA ask for ODB to be payer of second resort? There's a couple points to this. One, we did articulate what we saw as some gaps in the program, one being that it was inclusive of all children, whereas some already had insurances, and there could have been a program that was better if it was payer of second resort. That would be more cost saving to the government. So we did raise this with the government. The easy answer to this is, particularly the former Minister of Health had an extreme interest in universal pharmacare. This is a platform that they've built their policy on, and as many of you might be aware, the Minister of Health in Ontario, Minister Hoskins, has moved on actually to a role in the federal government to look at pharmacare again on a more national scale. This was something that they created, and they were pretty much unwilling, not just from us, but also from other groups. And I want to make that clear. OPA wasn't the only one to certainly make it vocal that this program had some, or could have operationally been a little bit better, but they seemed very unwilling to move on it. This is essentially a passion of this party to start implementing universal pharmacare. So we did. The concerns that were raised through the question, we did raise this. And as I said, multiple stakeholders raised it. But once the decision was made, this group was pretty much set in stone on how they were going to move forward. And to just, again, expand on another comment that was made related to something Alan had mentioned earlier, can we go into more detail about the non-disclosure agreements we sign with government and how that impacts how we communicate to members. It's a fairly tricky situation, and it's one that we're very cognizant of. I want to make sure people are aware. When we entered to this specifically on the $150 million piece, I would say we've learned some lessons on it that we'll be acutely aware of if we have to go down this road again. But the scenario that presented itself when in 2015, when the government wanted to take this route, was we're going to take $150 million from fees paid to pharmacy. If you guys want to participate in telling us how to take those fees, you need to sign these non-disclosure agreements to allow us to have discussions in the room without concerns of information leaking. I'm not saying it's necessarily a win for pharmacy to get that, but retrospectively, if you look at it, we would rather have some say in our fate about how government is dictating how they are removing funding from pharmacy than allowing them to make that decision without any input from our sector. And again, the people that were in the room, it was a cross-sector approach. It was us, chain drugstores, specifically long-term care pharmacies. We were all under the same non-disclosure agreement. So at the end of the day, for us to get in the room to have those discussions, it was a requirement, and we saw that as painful as it is, the only option we had at that time. Otherwise, they would dictate where and how they would take those funding from us.
If I can just add to Mike's comments, I think I made reference to it in some of my earlier comments before the Q&A session started, and that was I made reference to working with majority governments. We are currently in a scenario where we are dealing with a majority government, and when any advocacy organization is working with a majority government, there's very little leverage that can be had. Minority governments, you have a little bit of wiggle room because the government is less sturdy, on their feet. They need to consider, the impact of us going to another party to plead our cases. In a majority government, which is what we have now, they basically get to call the shots. So Mike said it very succinctly. They were already going down this path of implementing funding cuts that would take $150 million per year out of our system. And so we have no negotiating power. That said, we were invited to the table to provide input as to how this can be done with minimal impact to the profession as possible. On a related note, highlighting the word negotiate, a question came in: did OPA negotiate the training fee for the Narcan nasal sprays, as the amount is slightly less than that for the injectable? I got this question quite a bit when the program was recently expanded, and the rationale behind it was that when you look at the nature of the product, of the Narcan product, it is, I would arguably say, a little bit simpler to explain and to educate a patient on how to use it. When you're looking at the injectable version of naloxone, that requires not only a little bit of education on what the medication actually does, but also there is a requirement for pharmacists to educate the individual coming in on how to actually inject. And that's a very different type of consultation, and it was recognized that was outside of the normal dispensing fee, normal, usual, and customary dispensing fee services. And so there was a top-up that was provided, and you'll recall there was cost of product for the injectable, there was a $10 dispensing fee, and a $25 training fee. That $25 training fee accounted for the complexity of teaching someone how to administer an injection. With Narcan, that is analogous to certain other types of pharmaceutical products it's much simpler to educate on how to actually administer that. And so the government felt that that would be captured in a $10 fee. There would be no additional need for a training fee.
So one of the, again, shifting gears here, one of the questions that was asked was, when was the last time that ODB authorized a fee increase and not just the rural fee increase? And actually, the last time they did increase the fee was April 1st, 2013, if I recall correctly. And that was a part of the 2010 agreements where they had the fee at $7 and then increased it to $8 and then did a 2.5% increase year over year till 2013, which got us to the current number that we're at of $8.83. They also did, whether or not we saw a massive impact from this, they did shift the line on a low-income senior from 24,000. I'm ballparking the number, so I apologize, but 24,000 to about 32,000 for a household, which did move a lot of seniors from being in the $6.11 copay to the $2 copay, which on some levels had significant benefits to pharmacy because they were paying more fees, particularly in the areas of compliance packaging. So we're not saying it's positive, and this is something that we've been continuously raising with the government, that we are the lowest fee in Canada, and that it's something that we should, that they need to reconsider when they're negotiating with us, because it does have an impact. And I'll tell you, from an operational standpoint at OPA, one of the best things for us might be the expansion of OHIP Plus to seniors. Because one of our biggest downfalls anytime we've raised the dispensing fee issue with government is that pharmacy is throwing away $2 every time when we waive the $2 to seniors. So why would we need a fee increase? They're just trying to fix the problem we created. And at least when we have that cohesiveness amongst the fee between all providers within that group, it'll certainly support our argument a little bit more in the future when we go to government.
Question has come in as to what kind of negotiations do we have with third-party payers, and can OPA play a bigger role, especially with aggressive audits? And I know that Mike is itching to contribute to this one, but I'll take a first stab at this. Certainly we've seen over the past month, 2 months, some notices that have come out of either the private payers themselves or from the adjudicators, new policies that are they're posing significant operational challenges, and we have been trying to address these on a one-off basis. Right now, there is very little commonality across the payers, across the adjudicators, and everyone seems to be marching to their own individual drumbeat in terms of how they are going to adjudicate, how they are going to audit. About 2 years ago, a process was started working, it was OPA-led, working very closely with CPHA and working closely with CLIA, which is the association representing the insurers. There was discussions that began to look at establishing a level playing field, a more fair audit approach, and quite simply looking at best practices for audits. And this would be to apply to not only to auditors and private payers, but also to pharmacies. So there will be, first off, a greater understanding of the challenges that each side, provider and payer, the challenges that we are all facing, and what we are looking for, what pharmacy is looking for in terms of consistency. And so there will be, over the next couple of months, I believe, a webinar that will be scheduled, a national webinar that is going to look at unveiling the best practices for audits. Now, this is only a guidance document. It doesn't bind anyone, and from a payer perspective, but this is the starting point for broader discussions that will ultimately and hopefully lead to, a universal approach to audits, and it's multifaceted, and it's not going to be without its challenges. But that work has been completed. A final report is being compiled right now, and you can expect to hear a webinar that will be led by OPA and by CLIA to help explain that. Mike, and you may want to talk a little bit about some of the work that's going on nationally.
Thanks, Alan. So I do serve on a committee for that represents pharmacy amongst or the pharmacy sectors with collaboration with the private insurers across the country nationally to try to advise on issues like this. I think what's important to realize, one, we're in a much better state than we, pardon the pun, than we are from our friends in the States. We're much further ahead in terms of how third-party payers are at least interacting and engaging with pharmacy. And this forum that we have, where we do meet quarterly now with the insurance companies, or at least the representation, is kind of unique. And it's in its infancy, which sounds weird because we've been doing it now for about 4 or 5 years. But given this relationship hasn't really existed here in Canada or down to our friends in the South, it's something that we've spent a lot of the time just negotiating what we can talk about and what we can do collaboratively that benefits both parties. So we are starting down that road. I would say we've had a positive reception from the third-party payers and now the adjudicators, who are also members of CLIA. And I know Alan was speaking to probably one of the best things that's starting to come from that is the audit's best practice. And yes, it's a new document and needs some work and needs to grow, but it's a starting point. So we are out there. OPA is definitely out there. Either we do have direct representation on that, just with myself, but we also have CPHA, and again, OPA is a member of CPHA, so we do push our voice to make sure that it's being represented by CPHA on that issue.
So we have time for one more question, and we recognize that there are still many other questions that are in the queue, and we apologize just given the timing that we can't get to all of them, and we will do our best to get answers to the outstanding questions and communicate that through either our website or through electronic communications. However, the last question I'm going to address is, and I'll ask Mike to also comment on this, who do you suggest voting for given our political challenges? Very much a loaded question, and the very simple answer is OPA cannot direct anyone and really should not direct anyone to vote in any particular fashion. We recognize we live in the health space and in the business space, but elections are decided by a number of different aspects that are perhaps unrelated, and we may have personal views and positions on other non-health related issues, whether it be hydro, whether it be infrastructure, whether it be education. So these are all personal decisions. However, what I would say is take advantage of the campaign period, take advantage of the OPA advocacy kit that we have available, and start talking to your candidates, start talking from all parties. Ask them the hard questions and allow them to provide their perspective in terms of what they would do if they were to form the government. Every group, and I would suggest, all parties are going to have, things that they will promise, and all parties will have something that they will say, but the truth as to whether or not those will be implemented still remains to be unseen. And unfortunately, we cannot provide any type of guidance. Mike, anything you want to add on top of that?
My simple suggestion would be to anybody that has that question is to review each party's health platform, and you make a decision. If you're making a decision based on your pharmacy practice, review their health platforms and see which ones are favorable to pharmacy and favorable to health in general. So, all right, so we're at 6 o'clock, so that's about all the time we have. So we will wrap this up now, and I want to thank everyone first for participating. I hope people find this valuable. We hope to continue this in the future. We've been talking a lot of broad topics to start, just as we kind of dip our toe in this water. And hopefully, as we continue forward, they can be very, very focused on maybe one or two issues instead of all the issues we're facing at once. So be sure to register for OPA's Destination Conference, June 7th and 9th, Connecting the Dots at Deerhurst Resort in Huntsville. Our keynotes will include Bruce Croxon, who will discuss technology, as we mentioned before. Our second inspirational keynote will be from Melissa Sheldrick, who has turned her son's tragic and preventable death into a crusade for air reporting in Ontario and across the country. Her plight was once one we all felt in our core, and while it's an emotional message, it's also important that we ultimately strengthen our profession and reinforce our important role within the circle of care. We've also got sessions on medical cannabis, leadership, biologics, chemotherapy, toxicities, and more. Under the stars, we've also got a beach party, ice cream social, and formal closing for you to network with your peers and families. But one very important thing to remember, if you're planning to attend this fantastic event, the conference kickoff will be on Election Day, June 7th, so you'll need to take advantage of the advanced polling for your riding. OPA will remind members planning to attend the conference of when the advanced polling will begin, and don't forget to vote in this election.
If you're not a member, now is the time to join us in our collective fight for the profession. Please call the OPA office or visit our website at www.opatoday.com/professional/membership. As mentioned earlier, OPA will remain active now and throughout the aftermath of the election to determine what the new government will mean to all of us. Once the political direction has been determined, OPA will convene the next in this series of advocacy webinars to keep you posted and updated and involved and engaged on our collective paths moving forward. Please watch your OPA e-bulletins for more information on the date and time for our next webinar. We will make the slides and this broadcast available on our website. Once again, thank you for joining. Please ensure that you complete the survey that will pop up when you close the webinar. Good night, and we look forward to seeing you in Deerhurst.